therapy, chemical peels, derma fillers, thread lift, vitiligo surgery, mole excision, acne scar subcision. So, total number of OPD we see every day is around 100 patients. Last year we did around 2,092 skin biopsies, 2,611 electrosurgical procedures, 918 cryosurgical procedures, and 1,228 chemical peels. And lasers we are doing for hair reduction with diode laser 1,622, scar revision with CO2 laser 1,770, and pigment removal and tattoo removal with Q-switched Nd:YAG lasers we have done 1,218. And every day we are doing intralesional injections for different indications like alopecia areata and keloids, and we have done last year around 2008. We are giving phototherapy for different indication and especially narrowband UVB therapy, and we have given last year 2,415 patients. Our department is dedicated to research and publications. In last 5 years, we have published 77 papers, and in last year, 12 publications have been already published. And our students are now and then presenting papers and in the different conferences, and they are also presenting posters, and they have presented 93 posters and papers in last 5 years. And last year, 11 have been done. And our faculty is into submitting chapters to the books also. They have contributed chapters to different books also. We are regularly conducting workshops for hands-on training for our students, like for thread lift, botulinum toxin, chemical peels, hydrofacial, laser, PRP, fillers, workshops, etc. Then we are every time having interdepartmental meetings. Like last year we had 2 meetings with rheumatology departments, one with the ENT department and the obstetric and gynae department, emergency medicine department, and with pathology we are regularly discussing the histopathological slides. Our faculty has lots of laurels and achievements, and even students are having awards in different conferences for paper presentations. Our department is also doing field visits and outreach programs regularly, and also through talk shows on TV and through telemedicines also. Then as this is 25th year of our Mahatma Gandhi University, so we have certain future plans for the department. Like we want to upgrade the department with new lasers and make it a better aesthetic center with starting the fellowships in aesthetics and laser. And though we want to establish Institute of Excellence in Dermatology, so we need a better infrastructure also. So for this combined clinical round, discussion of the case, I am inviting Dr. Avani Verma, our second year resident. Avani, please.
A very good morning, emeritus faculty members, respected teachers, and my colleagues. Today, I, Dr. Avani Verma, second year PG resident, will be presenting a case about a 4-month-old infant with skin rash. The informant here is mother. A 4-month-old baby boy presented to our OPD with the chief complaints of red scaly lesions over the body since last 3 months, diarrhea since last 3 months, and fever since last 15 days. The baby was asymptomatic till 1 month of age when he developed diffuse, red-colored, lentil-sized scaly lesions over the body. The lesions initially began from the scalp and face and progressively increased in number to involve the trunk, followed by upper limbs and then the lower limbs. Few of the lesions exhibited spontaneous resolution over the next few days with hypopigmentation and without associated scarring. Also, there was presence of simultaneous occurrence of new lesions. The mother reported multiple episodes of diarrhea for the past 3 months. They were thin and watery in consistency, occurring 8 to 10 times per day. The stools were yellow in color, non-foul smelling, and without any blood or mucus. Each episode lasted for a duration of 5 to 6 days and relieved on its own. There was also a history of episodes of fever since last 15 days. The fever was of sudden onset and followed an intermittent pattern, with 1 to 2 spikes occurring each day. The fever was low to moderate grade, ranging from 100 to 108 degrees Fahrenheit in axilla, and was not associated with chills and rigor. Taking paracetamol oral suspension as prescribed by the pediatrician provided transient relief. The points we looked for: there was no intake of any medication or topical application prior to the onset of lesion. Complaints of nocturnal pruritus or similar lesions in the family was negative. Cough and runny nose was not present. The baby had not been fed goat or cow milk. There was no vomiting. Family history for atopy, allergies or asthma was negative. Maternal history of genital ulceration or any skin involvement was not present. The mother informed about routine multiple OPD visits for the above said complaints, and the treatment given were antibiotics, paracetamol, ORS, and local application of fusidic acid cream. But the child responded only partially, and the symptoms kept recurring. There was no past history of hospitalization or surgery. The mother was a Gravida 1, Para 1, with 1 live birth and no abortion, and a booked case with 8 ANC visits. Antenatally, HIV, VDRL, TOT screening was done, which came out to be negative. Antenatal period was uneventful. There was no history of rash or fever during pregnancy. The baby was a full-term normal vaginal delivery with a birth weight of 2.8 kgs. He was delivered institutionally and he cried soon after birth. Postnatal history was uneventful. The baby passed meconium soon after birth. They were discharged from the hospital 3 days after the delivery. The baby was partially immunized with only BCG, oral polio vaccine and hepatitis B vaccine given at birth. In dietary history, the baby was exclusively breastfeeding till 1 month of age, and then he was shifted to formula plus breastfeed milk combination in the ratio of 3:2, and he takes approximately 5 to 6 feeds per day with approximate total calorie intake of 400 kilocalories. Family history: the baby is a product of a non-consanguineous marriage. There is no history of similar illnesses in the family on either paternal or maternal side. In this 3-degree generational pedigree chart, we can see the affected baby is a single male child and no significant history in the last 2 generations can be seen. Modified Kuppu-Swamy score was calculated, placing them in the lower middle class strata. Now, before going to the detailed dermatological examination, just to refresh everyone's memory, let's quickly discuss the basic skin lesion terminology, as we will be using these terms further in our examination. First, we have flat, non-palpable lesions which is less than a centimeter, then it is called a macule, and patch is called when such kind of lesions is more than 1 centimeter. Next up, we have raised palpable lesions which is less than a centimeter and is termed as a papule, and if is more than a centimeter, we call it as a plaque. Now, scale is a term used when there is presence of any abnormal shelling or accumulation of stratum corneum in form of visible flakes. Small, red, non-blanchable, pinpoint lesions of 1 to 3 mm in size is called a petechiae, and if the lesions are larger and raised, we call it a purpura. So now proceeding further with our examination, the sites involved were scalp, face, trunk, upper and lower extremities extended to palms and soles. On the scalp, we saw presence of greasy, adherent, yellow-colored coarse scales. Over the neck and bilateral axilla, we observed multiple erythematous scaly plaques of varying sizes. On examination of the abdomen, there was presence of flat, purpuric macules along with hypopigmented macules. And on few focal erythematous plaques there was presence of overlying yellow-colored coarse adherent scale. Lesions of similar morphology were appreciated on the back. Over bilateral palms, there were scaly erythematous papules and plaque, and soles had hypopigmented macules. So we have a patient who had a presentation of polymorphous lesions. During the examination of oral mucosa, there was 2 upper incisors and 1 lower molar, which on inquiring the mother informed had been present since birth, indicating natal tooth eruption. Rest of the oral mucosa examination was normal. Now to summarize, we have a case of a 4-month-old baby boy having polymorphous skin lesions as discussed since last 3 months, multiple episodes of diarrhea since last 3 months, and intermittent low to moderate grade fever since last 15 days. We completed a detailed dermatological examination, and with the baby's age being 4 months, having diarrhea and fever, a pediatric consult alongside was taken for expert opinion. I would like to invite Dr. Shipra from Department of Pediatrics to discuss combined general physical and systemic examination of the baby.
Thank you so much, Dr. Avani. Good morning, everyone. So, we have a 4-month-old male baby referred from the Department of Dermatology with a history of red scaly lesions over the body for last 3 months, diarrhea for last 3 months, and fever for last 15 days. On the general physical examination, baby was examined in mother's lap and lying on poster. Baby was awake and irritable with a GCS of E4, M6, V4. Baby appeared wasted and stunted. Pallor was evident on face, palmar creases and soles. And there was no evidence of dehydration, respiratory distress, cyanosis, icterus, facial dysmorphism and edema. When we assess the vital parameters, patient's body temperature was recorded as 98 degrees Fahrenheit, which is within the normal range, taken in the right axilla using a digital thermometer. The pulses were 140 pulsations per minute, were regular, without any radioradial or radiofemoral delay. The patient had a respiratory rate of 38 breaths per minute with a thoracoabdominal breathing pattern, which is normal for his age. BP was measured in all 4 limbs and was within the normal and had no significant difference. It was 76 by 52 mm of Hg in the right upper limb in a supine posture using the auscultatory method. The saturation was 97% on room air, which is adequate, and the capillary refill time was less than 3 seconds, indicating a good peripheral perfusion. On anthropometric assessment, growth parameters were recorded using the standard growth methods and were plotted on the WHO IAP growth charts, indicating the curves from the 3rd centile to the 97th centile. The green curve here represents the 3rd centile, and this curve represents the 97th centile. And when we plotted the patient's growth parameters that are represented by this dot, they lied below the 3rd centile. However, the head circumference for his age was normal. These findings highlight that the patient in question has a growth failure. On head-to-toe examination, the head circumference was 42 centimeters. It was normal in shape. The anterior fontanelle was open. The posterior fontanelle closed. The baby had a presentation like seborrheic dermatitis or cradle cap around the anterior fontanelle. The hair were black, sparse, fine in texture in parietal, temporal, and occipital region. The forehead examination, eye examination, nose examination, and ear examination was normal. On oral cavity examination, natal teeth were present, 2 upper incisors and 1 lower molar. The mucosa was pale. No swelling was observed in neck. Polymorphic skin lesions, scaly erythematous macules and papules, purpuric macules, hypopigmented papules were observed in the thorax and back, upper and lower extremities extending to the palms and soles, as discussed previously in the detailed dermatological examination by Dr. Avani. The skeletal examination was normal and the genitalia was consistent with the male sex. When we did the developmental assessment, the head lied below the trunk during ventral suspension. The patient was unable to lift the head off the couch in prone position, and the head lag was present when pulled to sit. In fine motor assessment, we observed that the fist remained closed and the hand regard was absent. Delay was also observed on the social front. In vocalization, cooing was absent. When we assessed the vision, baby could not follow the objects, could not hear sounds, and the grasp reflex was persistent. These findings suggest a developmental age of 2 months and a chronological age of 4 months. So when we divide the developmental age by the chronological age, we get the developmental quotient, which in our patient was 0.5. This suggests a significant deviation from the normal in all domains indicating of global developmental delay. As the patient had a history of recurrent diarrhea, we are now upfront discussing the gastrointestinal examination. On inspection, the abdomen appeared distended, fullness was seen in both flanks, the umbilicus was everted. On palpation, the liver was palpable, the lower border of the liver was palpable 12 cm below the right costal margin in mid-clavicular line, had a smooth surface with regular margin, was firm in consistency and non-pulsatile. The spleen was 8 cm enlarged below the left costal margin towards the umbilicus. It was firm in consistency, non-tender with a palpable splenic notch. The findings on palpation were suggestive of hepatosplenomegaly. On percussion, the liver span was 16 cm, whereas the normal for his age is 5 to 6 cm. On auscultations, the bowel sounds were normal, and the genitalia was normal and consistent with the male sex. As the patient had global developmental delay, we did a detailed age-appropriate central nervous system examination and presence of grasp reflex was noted. No abnormality was detected in examination of other systems. To take this presentation forward, I would like to invite Dr. Avani.
To summarize, we have a 4-month baby.
Just one minor semantic correction. It's not gastrointestinal examination, it is abdominal examination.
So, I'd like to also ask you here, when you use the pronoun for the baby, you're using it. So at what age do you shift to he and him, and till when do you continue it? Is there a cutoff in pediatrics? Like just like a light question.
No, so there is no cutoff. That was not.
Then is there a specific reason of calling the male child it?
No, sir.
To summarize, we have a 4-month baby boy from a non-consanguineous marriage with chronic diarrhea since last 3 months, intermittent low to moderate grade fever since last 15 days, polymorphic lesions as discussed. Now new findings were hepatosplenomegaly, growth failure and delayed milestones. Now with the above said summary, I would like to ask the audience what all differentials can we think of? Anyone?
Does the natal tooth eruption has any importance? I mean, you have not mentioned it in the summary. Is it an important finding? Does it indicate towards anything? If yes, then it should be included in the summary.
Okay.
Summary should include all positive and maybe some important negative points also.
Noted.
The first picture we saw of the baby, was it giving the look of a hepatosplenomegaly there
Yes,
also?
sir. Yes.
So we probably did not mention it at that time. Mother's history with respect to vis-a-vis, let us say, herpes or something.
So for that, we did investigations further in our course. So in the inflammatory causes, seborrheic dermatitis, atopic dermatitis and contact dermatitis was kept as a possibility. In infectious and infestations, the congenital causes were torch and syphilis, while the acquired causes were HIV, scabies and neonatal candidiasis. Metabolic causes included lactose intolerance, while LCH was considered under a neoplastic cause. and a possibility of congenital immunodeficiency was kept. Proceeding with the investigations, we started with a bedside workup in our OPD. Since skin scrapings from the lesions were taken and a KOH mount was made, which was negative, ruling out candidiasis. A mineral oil preparation was made from the scrapings of the lesions, which was negative, thus ruling out scabies. And a Zank smear was performed, which was negative, thus ruling out herpes. On complete blood count, it showed a picture of anemia and thrombocytopenia, with hemoglobin being only 6.5 gram per dl and 1.2 lakh platelets respectively. Liver function test showed hypoalbuminemia, rest parameters were within normal limits, urine routine and renal function test was within normal limit. HIV, anti-HCV was non-reactive, HBS antigen, VDRL and torch panel was negative. CRP was raised and USG whole abdomen reported hepatosplenomegaly. And stool for reducing substances was negative. Based on the detailed history and examination, bedside workup and investigations, we were able to rule out some of our differentials. Atopic dermatitis was ruled out as there was no history of atopy, allergy or asthma. Therefore, and there was no history of topical application prior to the onset of lesions. Therefore, contact dermatitis was ruled out. TOT screening was done, which was negative, thus we ruled it out. There was no history of paternal or maternal genital ulceration, and also VDRL was negative, thus we ruled out syphilis. HIV was non-reactive. Scabies was ruled out as there was no complaint of nocturnal pruritus or of similar lesions in the family, and on scrapings, no mites were seen. Neonatal candidiasis was ruled out as there was no fungus seen on KOH mount. Stool for reducing substance came out to be negative, thus we ruled out lactose intolerance. So now we are left with the following possibilities. In the inflammatory cause, seborrheic dermatitis was kept, though unlikely as it is not accompanied by purpuric lesions and systemic symptoms and hepatosplenomegaly. Second differential was congenital immunodeficiency, and third, under neoplastic causes, leprosy disease variant of Langerhans histiocytosis was kept. Skin biopsy and further evaluation was planned. So now we have a baby with above kept differentials, having chronic symptoms and also hematological abnormalities. So in this regard, we refer the baby for further evaluation to Department of Clinical Hematology. I would like to invite Dr. Disha Satya to discuss the same.
Thank you, Dr. Avani. I'll be discussing the clinical hematology part of the case. So, the 4-month-old male child was referred to us in view of anemia and thrombocytopenia along with hepatosplenomegaly and other features as discussed earlier. Considering the overall symptoms, sign and initial workup, a differential diagnosis of infective etiology like TORCH, neoplastic etiology like Langerhans cell histiocytosis, acute leukemia, neuroblastoma, and possibilities of other rare like primary immunodeficiency disorders were reflected on. To further narrow down our differential diagnosis, additional workup was conducted. A peripheral blood film showed microcytic hypochromic RBCs as shown by the red arrow, and along with reduced platelet and few giant platelets as shown in the picture by the green arrow. There were no immature cells, thus making the acute leukemia less likely. Serum ferritin was within normal range, making the possibility of HLH less likely. We did a bone marrow aspiration and biopsy along with skin biopsy. We had also planned to do additional workup for primary immunodeficiency diseases. So bone marrow aspiration, biopsy and skin biopsies are both invasive procedures, and they required the use of sedation in infant and children. They were both done in a single sedation. Now I'd like to ask the audience, what are the common sites for bone marrow aspiration and biopsy? The medicine and pediatric
ये तो
residents.
बताना पड़ेगा 4 साल के बच्चे के बारे में नहीं मालूम फाइन बट दिस यू हैव टू से मेडिसिन रेजिडेंट कौन है ऑडियंस में सेकंड ईयर थर्ड ईयर मेडिसिन रेजिडेंट एक भी नहीं है फिर मैं आप तुम्हारे हेड को बोलूँगा बताने खड़े हो आइडेंटिफाई या एनीबॉडी कम ऑन वॉलंटियर यू डू इट राइट एंड लेफ्ट एवरी डे यस So posterior superior lies fine. Can you do that in a 4-month-old baby? Other sides?
So the answer is correct. So the most common site is the posterior superior iliac crest of spine, and tibial tuberosity is the preferred site for children. But in this patient, we prefer to do it from the PSIS to get an optimal sample. The smallest available needle, Sala's gauge needle, was used for the aspiration. A 13 gauge Jamshedi needle was used for the bone marrow biopsy. Skin biopsy was done by the Department of Dermatology, and both the samples were sent for histopathology analysis. I would like to call Dr. Kushu Sharma from the Department of Oncopathology to discuss further about the case.
Thank you, Dr. Disha. Good morning, senior faculty members and colleagues. I'll be discussing the hematological and histopathological aspects of this case. So we received specimen of bone marrow aspirate biopsy as well as skin biopsy in our department. Bone marrow aspirate smears were cellular for age and they showed trilineage differentiation with normal maturation. There were no atypical cells seen. Bone marrow biopsy was also showing similar findings, and it was cellular marrow showing no morphological evidence of disease involvement. We received the specimen of skin biopsy which was routinely processed and stained, and the left hand side photomicrograph is of skin biopsy section which is showing flattening of the epidermis, and the upper dermis shows a diffuse infiltrate of histiocyte-like cells. So on higher magnification we can appreciate that these cells are having abundant eosinophilic cytoplasm, elongated nuclei, and prominent nuclear grooving as is pointed by the blue arrow. Admixed in between is the inflammatory cell infiltrate, which was predominantly comprising of eosinophils as pointed out by the red arrow. So based on these morphological findings, provisional diagnosis of Langerhans cell histiocytosis was made, and we proceeded further with the immunohistochemistry to confirm this diagnosis. So on immunohistochemistry, we chose a IHC panel which comprised of IHC stains which are specific for Langerhans cell histiocytosis, which are Langerin and CD1A. So the left hand side photomicrograph shows strong immunopositivity for Langerin, and the right hand side image is showing positivity for CD1A. So based on these findings, we made the diagnosis of Langerhans cell histiocytosis. So to summarize this case, we received a skin biopsy which was showing histiocyte-like cells which are having abundant eosinophilic cytoplasm, elongated nuclei with prominent longitudinal nuclear grooves, and admixed in between is the inflammatory milieu comprising predominantly of eosinophils. On immunohistochemistry, these cells showed strong immunopositivity for CD1A and Langerin. So a final impression of Langerhans cell histiocytosis was given. The bone marrow aspirate and biopsy was cellular, but there was no morphological evidence of disease involvement seen. So to conclude, the final diagnosis given on skin biopsy was Langerhans cell histiocytosis, and on bone marrow aspirate and biopsy there was no morphological evidence of disease involvement. Now I would like to invite Dr. Avani to proceed further with the case.
So to summarize, we have a 4-month-old baby boy with skin lesions as discussed, diarrhea, fever, poor weight gain, delayed milestones, anemia and thrombocytopenia, and hepatosplenomegaly. With histopathological examination concomitant with cells with scant cytoplasm and reniform nucleus, and immunohistochemistry positive for Langerin and CD1A. Juxtaposing the histopathological and immunohistochemistry findings on the clinical picture, our final diagnosis of letter C variant of Langerhans cell histiocytosis was made. Since it is a neoplastic disorder, the baby was referred to the Department of Clinical Hematology for further management, and in the meantime, topical adjunct therapy was started. I would like to invite Dr. Disha Satya back to discuss the management of this baby.
I will now be discussing the management of this case. So definitive diagnosis of Langerhans cell histiocytosis requires a combination of clinical presentation, histology, immunohistochemistry. Once we have established the diagnosis of LCH on the basis of histopathology, next step is to stage the disease. There may be single system involvement or multi-system involvement. The common systems involved are the skin, liver, spleen, CNS, lung, and bone. So for the staging, we did a whole body PET CT scan. It is a single investigation to stage and monitor the disease activity. It showed massive hepatosplenomegaly, metabolically inactive diffuse ground glass changes, intralobular, interlobular septal thickening in both lung fields, metabolically inactive multiple subcentimetric small subtle skin, subcutaneous thickening at the anterior thoracic abdominal wall and bilateral palm regions. So PET is a useful modality to evaluate therapy, but radiation burden, need for sedation, cost and availability limits its usefulness. As the patient had involvement of skin, liver, spleen and lungs, our patient was classified as multisystem LCH. Risk organ involvement assessment is considered crucial as it plays a major role in management and overall prognosis. Our patient had involvement of spleen and liver. We also did a molecular analysis in our patient and V600E mutation was detected in the BRAF gene. Although LCH was once considered a disorder of immune regulation, the identification of activating mutations in the proto-oncogene BRAF has changed the definition of LCH to a dendritic cell neoplasm with a strong inflammatory component. Based on the available clinical details and diagnosis investigations, our final diagnosis is the multisystem Langerhans cell histiocytosis with risk organ involvement and BRAF mutation. The patient was started on treatment as per the LCH4 protocol as discussed in the multidisciplinary tumor board. The induction chemotherapy, which comprises of vinblastine 6 mg per meter square weekly for 6 weeks as denoted by the arrow, and prednisolone 40 mg per meter square per day for 6 weeks. So to administer chemotherapy in a 4-month-old child is challenging, and after starting treatment, the child showed good response. So in the first week, erythema decreased and there were no new lesions. Fever and diarrhea subsided. Patient developed hypertension due to steroids and was started on enalapril and labetalol. A pediatric cardiology reference was taken and furosemide was added. In the second and third week, the patient developed pneumonia requiring an IV support and in the PICU. Chemotherapy was withheld for 10 days. And in the fourth and fifth week, the treatment was restarted and in view of hypertension, dose of prednisolone was reduced. The oral intake improved, skin lesions were reduced and regressed, and the liver regressed by 2 centimeters and spleen by 3 centimeters. So by the end of 8 weeks, the liver regressed further by 2 centimeters and spleen further by 2 centimeters. The skin lesions on the pus, there was a skin lesion, pustules in the palm that responded to topical antibiotics. So the further course response assessment was done at 8 weeks and there was regression of signs and symptoms with no new lesions. So the patient has been started on second induction with vinblastine and prednisolone, and response assessment at 12 weeks will guide further treatment. So plan is maintenance if resolution of all signs and symptoms occur. So the outcome of multisystem LCH, so the study was done at PG at Chandigarh and showed an overall survival of 68.9% at 5 years in patients of multisystem LCH with risk organ involvement. And another study that was conducted at the US showed 11% patients with skin-limited disease and requiring second therapy due to disease progression, while 56% of patients with multisystem LCH requiring second therapy in view of disease progression. So now I would like to invite Dr. Avani to carry the session forward.
So Disha, 4-year-old child, 4-month-old child, and weekly injections of extremely irritant chemotherapy drugs in the vein, did you consider venous access, long-term venous access in this patient, or did you manage with the peripheral vein?
So it was managed with the peripheral vein, although long-term venous access would have been a better choice. The patient was managed with IV cannula.
Dr. Disha, I have a query for you.
Right.
You said that the patient had a macrocytic hypochromic anemia in the PBF. Keeping in view a normal serum ferritin in this patient, what cause is ascribed to that macrocytic hypochromic part?
Yes, sir. So the patient had been having symptoms since past 3 months. So since 1 month of age. I would attribute that to the anemia of chronic disease, and also it could be the baby could be carrying a thal trait, which we would have to rule out.
This baby was having chronic diarrhea also, no? He
Right,
had
sir.
episode of diarrhea.
So the first possibility.
Baby had low albumin and
there were features of malabsorption were there because there was a growth retardation. So there has to be some involvement of the gut which leads to chronic diarrhea. And especially when there is no blood in the stool, then the large bowel is less likely. And those babies who have weight loss with such diarrhea, we should do a detailed examination of the stool to see for any evidence of malabsorption, especially fat and all, because the mother's milk contains fat and that should be done. And the other point which I want to make here is that this patient presented with skin lesions and hepatosplenomegaly and chronic diarrhea. And what is the cause of diarrhea in such patients with histiocytosis? And the other thing is that with such a huge hepatosplenomegaly, especially when it is responding to the treatment, what is the histopathology we have, histopathological involvement of liver and spleen?
Right. So we have not done the histological
So we
examination.
should know at least the literature, you know.
Right.
If you have a diagnosis simply on a skin biopsy, then you have not gone ahead to do a liver biopsy, but still we should know what happens.
From the clinical examination, it was almost obvious that this is a multi-system disease. So how did the PET add to our management? Could it have been avoided?
So PET modality can be used further also to monitor the disease burden, and or even though there were no metabolically active lesions, they were only in the palms and the skin
So
of
I'm
the
saying
abdomen.
only because it is a 4-month-old child, again for PET you must have given anesthesia.
Right.
Response to treatment you can easily assess by the skin lesions and liver and spleen, which you mentioned also. So I'm just asking that was it discussed and could we have avoided PET?
Sir, may I answer this question? Sir, there is LCH has been almost 80% patients have also involvement of bone. So if we would have not done PET, we would have to do the entire skeletal X-rays. We would have to do MRI of the body and to look, especially look for the bony lesions. So that is why we did a single investigation so that we can look at the bony lesions as well as the marrow involvement as well. So that is why the PET was planned. The answer to the question of microcytic. Yes.
My point is, even before PET, you knew that this is a multi-system disease.
Yes,
So
sir.
treatment would have remained the same.
Yes, sir. But sir, evaluating all the systems is important. Like when we, since
Important from what point of view?
so resolution of each and every lesion is important when we follow up the patient. So had it been like he had some bony lesions which would have missed, or at a critical site, maybe in the skull or in the spine, we would like to know those at the time of
So
diagnosis.
would it have changed the management?
Yes, sir. If it is a high-risk lesion involving any cranial bone, it would have changed the management. We would have to maybe irradiate that particular site or do a particular management for that local site. For microcytic hypochromic anemia, sir, it's an inflammatory disorder, and that is why probably he had both anemia as well as thrombocytopenia as a manifestation of the systemic disease. So that could be one of the cause. And sir, regarding the hypoalbuminemia and liver, yes, so it is a clinical classification as we saw in the LCS. So proving the histopathological diagnosis at single site is okay. We need not do biopsy at each and every site.
No,
So that
was
is
not
why.
the point. Actually, it's such a rare disease, we should know what is the histology. I mean, in the literature, not in this paper.
Yes, sir. Yes.
With the ongoing chemotherapy, we saw sequential improvement in the skin lesions of the baby. This was the picture at the diagnosis at week 4 and at week 8. There was also sequential improvement in the cradle cap area. Now, reviewing the literature, histiocytosis is broadly divided into 5 groups, namely L, C, R, H and M. Our focus today is on Langerhans cell group. Langerhans cell histiocytosis is a rare clonal proliferative disorder involving Langerhans cells. Primarily affects pediatric population but also seen in adults. The annual incidence is only 5 per million in pediatric population. The pathogenesis, 50 to 60% of the cases have mitogen activated protein kinase pathway mutations like BRAF as in our case. CD1A, S100, Langerhans positivity is a hallmark. And due to cytokine drive inflammatory response, tissue destruction is observed. Clinical manifestation of LCH vary. There can be a single system or multi-system involvement. Single system can involve either single or multiple site. Multiple system involvement is a disseminated disease having low and high risk group. Our case, letter C variant, was multi-system Langerhans cell histiocytosis with high risk group. Briefly touching upon the variants, Hashimoto-Pritzker, which is a self-healing variant having localizing skin lesions and has an excellent prognosis. Another localized variant is eosinophilic granuloma, having occasional skin lesions and also has a good prognosis. Next up is Hand-Schiller-Christian variant, is of chronic progressive nature, having systemic features like diabetes insipidus, bone lesions and exophthalmos. Lastly, leprosy disease. The case for today's discussion is a rare case having only 1 or 2 cases per million per year presenting in children less than 2 years of age. Skin involvement is there in form of polymorphic lesion as seen in our case summarized on the side. As papillopustular eruptions showing seborrheic-like presentation, purpuric lesions which is associated with poor prognosis. It has the most aggressive course among all. It can be lethal if left untreated. Other systems like bones, liver, spleen, lymph nodes and lungs can be involved. In our case, liver, spleen and lungs was involved. In view of the rarity of the disease, most of the publications available are in form of case reports. So why this case? We've just heard the story of an uncommon condition, leprosy disease. At first glance, the skin rash seems simple, mimicking common presentations like seborrheic dermatitis and infections. With detailed history, examination, thorough investigational workup and investigations, and a right clinical approach, we were able to arrive at a crucial diagnosis of leprosy disease, which is often fatal if left untreated. This case shows how important it is to look beyond the surface. Secondly, using the right tools, skin biopsy and immunohistochemistry, and having to be in a setting which provides multidisciplinary approach. With the help of collaborating departments, we were able to promptly arrive at a definitive diagnosis and the treatment was initiated, leading to a successful outcome. I would like to extend my heartfelt thanks to the management of MGUMST, collaborating departments, CCR review committee, nursing staff, and most importantly, the patient and family. Thank you so much.